Thank you. All right, we're going to go ahead and get started with our second session of our Telehealth 101 Affinity group. Thank you all for joining us. I am Mary Erickson, the Program Director for the CMS Task Order, and I have a great team with me today to continue to help you along your telehealth journey. As before, I just want to put out there this little disclaimer that says that we're doing the best we can to keep up with the changing information. And I believe there's even new information this week from last week around billing and a few things. So trying to keep up the best that we can, and please consult any other necessary professionals or regulatory agencies for more updated information as needed. A couple of logistics. We have muted everyone, so if you would like to speak during the presentation, we encourage you to put in chat that you have something to say, or we can open up everybody to speak at the end for sure. Please also enter your questions in the chat box, and I would like to just point out we want this to be an interactive sharing session. So if you're not seeing the chat on your screen right now, you can go to your controls and hover over, you might have to hover over more to get the chat box to show up. But if you please do that, we're also going to be asking you some questions in the chat box to keep this an engaging experience for everybody. This presentation will be recorded or is being recorded, and all of the materials, slides, recording, and any handouts will be sent out to the registered participants automatically after the event, probably likely on Monday. Please do share with us your experiences that you're having, whether they're good or whether they're areas that you need some assistance. And of course, be kind as we're learning all this together. We're going to move through things pretty quickly today. We really wanted to make this kind of a quick session, but we wanted to show you that we have a new telehealth website. We'll put that link out with everything. When we talked to our stakeholder group about what was needed with telehealth, it was really kind of a one-stop shop for all of you to access resources quickly that might be on several different websites. So we'll be sending out our link to this website that we've put together in the last few weeks here, and it does have additional links to all of our partners as well. And it has a FAQ section that we've started populating with the questions and things that we're getting. Additionally, it has a contact us section where you can let us know what kinds of questions you're running into, and then we will make sure that those get to the right expert for you to get the best answer possible. So today we are going to hear from Susan Clark a little bit more about the HIPAA security, and we're going to hear some more from Amber Rogers and Dr. Arzubi on the billing side of things. So we're not going to ask a formal poll, but if you would just kind of put into chat how telehealth is going for you, how many visits were you able to complete this last week? Are there things that have been easier than you expected? And what is your biggest hurdle right now that we can potentially help you? And Catherine Larson at Kalispell Regional, if we could please promote her to a panelist so that she can just kind of chime in a little bit. She agreed, hopefully, she agreed to this. I was told she agreed to kind of share her experience with telehealth. Catherine, are you able to speak up? I'm hearing something. Is that Catherine?
Got me?
Yep.
All right.
I can hear you just a little bit.
We go out and come back in. So you know.
Get a little closer to your mic.
Yeah. Thank you for having me. I was asked to do this by Amber, and so Kalispell Regional Health is, I would say we're probably in the moderately advanced stages of the telehealth shift. We embarked on the journey on March 9th, and myself, our virtual health manager, Nicole Parisho, 2 tech support gentleman who worked for our education department, and then a third nurse came on board, pretty much standing up for the organization. We have, at this point, figured out the billing pieces of it. That's all been pretty seamless. Our billing team was on point, developing some FAQs and some guidance charts. And workflow is still somewhat in the works. Every clinic in our ambulatory setting is pretty specific in their staffing at this point. And so best workflow that we have found has been engaging the patient at the point of physician identification, that they are a valuable candidate for telehealth, and then the front desk offering that patient the chance to connect with their physician via telehealth, walking them through the testing process of our platform. We use LifeSize at the moment. And then at the point of the visit, once the patient has been tested and everything has been worked out, the most successful process that we've had so far has been that the MA or the physician support is contacting that patient, completing their med reconciliation, doing the initial assessment pieces, and then walking that patient into the virtual exam room. Every one of our clinicians has their own virtual exam room. A couple of them actually have two because they want to be able to move at a little faster pace. The HIPAA piece, we have navigated completely. We have an online PSA, a patient service agreement, as well as our telehealth consent that patients are directed to before their visit. They just have to verbally consent, and we document that both in the chart note from the physician as well as in their demographics, indicating that they have verbally consented during this the crisis. And then you know, staff buy-in has been pretty unbelievable. I think it's a little overwhelming for some clinics. Our primary care have been asked to stand up both a respiratory triage as well as the ED triage. So they're kind of at max capacity, but for the most part, we have two clinics that are only doing telehealth, and they're doing that for most of the primary care service line. Any patient can go there. And then we also have physicians both seeing patients in the walk-in capacity as well as in the telemedicine capacity. In the last week, organizationally, and I apologize, I didn't come with this number on the top of my head, but we have definitely crested 4,000 telehealth visits this last week. So pretty, I'm sorry, that would be in the month of April. So that's been a pretty big win for us, and I can get updated numbers on that, but we are tracking that piece of it. Patient willingness, you know, that's across the board. We have so many positive patient satisfaction coming back in. I mean, almost to the point where we're waiting for the other shoe to drop and there to be some negative comments. But I think at this point in time, patients feel so much more at ease with having been able to connect with anybody at this point if they have medical concerns, that once the snags were worked out and everyone recognizes this is different than our inpatient, our patient provider contact, everyone's been pretty good. Our biggest barrier has just been that patients don't have access to the internet or to a device that they can connect on, or that they, they don't qualify for that kind of care. Buy-in from providers is really pretty good, honestly. Again, I think it goes back to those who have patients that are very easy to see display. I know our internal medicine team has really embraced this, and even though they work with our oldest population, they are seeing 70, 80 patients this way during the week, as well as seeing patients in the clinic. Staff from buy-in from staff has been really good. Probably our biggest hurdle right now is just the technology gap with some patients, and that piece of it just is going to continue to be something that we're working for at the larger level. And other than the one or two clinics that still feel like they need some extra hip support, I feel like we've kind of ironed out a bunch of the bigger wrinkles.
Great. Thank you, Catherine. That sounds like you've had some great experience there and making some huge headway. Thank you so much for sharing with that. And thank you for those of you that are starting to share some things in chat as well. So if you have questions for Catherine, you can also put those in chat as well. Thank you so much. We're going to go ahead and move on now and hear a little bit more from Susan Clark on the HIPAA security stuff, a little bit deeper dive than what we did last week. Go ahead, Susan.
Thank you, Mary, and thank you everybody for attending today and spending some of your very valuable time with us. That was great to hear from Catherine about the number of telehealth visits. That's very encouraging out there. And just to kind of know too that, you know, that technology gap, I don't think you're alone in that. It does kind of make you wonder if, you know, maybe some of the platforms are better than others. But anyways, I'm just going to talk about a little bit of, I'm going to go through this kind of quickly. Like Mary said, we're going to try to, you know, have this be a little bit more interactive, but just to let everybody know, I'm basically really on the HIPAA front of all this. I just attended quite a long webinar with OCR. There's been a lot of changes. And so I'm going to go ahead and post a couple of listservs on chat that I would definitely recommend for folks. But basically, yeah, HIPAA has basically, you know, stood down. This was one of the early March regulations that came down, or waivers that came down. So we know that not all technology is going to fully comply, and that's totally fine at this time. OCR is exercising enforcement discretion, and you really just want to do that good faith provision. And so that's some of those, we're going to talk a little bit about some of those platforms that are available that I like to call patient friendly because they're already using them. OCR will not impose penalties against covered healthcare providers for lack of business associate agreements. As you know, in order to be HIPAA compliant, you really do need that business associate agreement. And then also it applies to any telehealth service. It's not just COVID-19. And the other thing I'd like to add to this for some folks that are thinking, or that fall under the 42 CFR regulations, it would be considered a medical emergency. So keep that in mind for that set of regulations. So next slide, Mary. So those technologies that are considered non-public facing, there's a list of them here. And this sometimes this trips people up a bit, you know, because there's non-public facing, these ones are okay to use, the public facing aren't. By non-public facing, they mean applications that are somewhat just between, you know, like what we're having today. If you're to use an application, we'll talk about it in the next slide, that is public facing, it would be like a Facebook type of thing, where you post it, it goes everywhere. So non-public facing means that it's a little bit more personal. It's like your Google Hangouts or your Skype. So these are the applications that they have said are okay for telehealth for this period of time. But you should probably, it'd be a good idea to notify patients. There could be some privacy risks with some of these. And there's also the opportunity to enable some encryption and some privacy mode. So you'd want to look for that as well. Next slide, Mary. And so what we did pull together to try to help with some of these is that we did a security assessment on them, and this is available on our website. And it really just talks about what is available in terms of some of the security. Surprisingly, some of them are actually more secure than some people might think. Apple FaceTime is a great example. They use link-to-link encryption. So if you're thinking about using any of these platforms that, again, I kind of call them patient-friendly because they're applications that probably a lot of people use every day, you know, to communicate with family members or so forth. So again, just for this period of time, we're always going to encourage you to put together a more sustainable telehealth approach that you're going to need down the road. But if you're in a pinch, I think these could work very well for you. Oh, that's okay, Mary, go ahead. And then just quickly, really quick, I want to mention some of the compliance pitfalls because, like I said, my world is HIPAA. So be careful again about disclosures to media. This is a real public time right now. So people are under a lot of pressure, but be careful about social media and media. Be very careful. Also, we've seen some record snooping. Remember that even though HIPAA compliance, some of the regulations have been relaxed, we still have minimum necessary. We still have to adhere to that. And then security for remote workers. Again, lots of people are at home now working, so they're really, you know, there's some security risks there, so be aware of those. And then also stress or panic-led disclosures. So again, minimum necessary and being cautious of that. So again, I actually think I did. I posted the listservs on the bottom of this. I forgot I did that. So if all of this is kind of not familiar with you at all, make sure you click on those listservs and get signed up. And then you'll start getting the bulletins if you're not already doing that. So that's my piece, Mary. Thank you, everybody.
Awesome. Thanks, Susan. That was great. So our billing and reimbursement, go ahead and go to the next slide. So I just first wanted to reiterate the fact that your billing and coding from before opening up the blanket waiver for telehealth was exactly the same as it is now. So when you used your medical decision-making or your time-based calculation to select your CPT code, that remains completely the same. So that should not be challenging for you at all. The things that have changed really were some different, when they first started the blanket waivers, they had a lot of variation in the way that they wanted you to, how they wanted you to place things on the claim file. So for Medicare, you will want to bill place of service of wherever the patient was if they would have seen the patient in person. So if you're talking about an office setting, you would use place of service 11. If it is a commercial payer, they want you to use place of service 02, which is telehealth. The modifiers, again, the CMS will want you to use your modifier 95. That tells CMS that that visit was done through telehealth. And then your commercial payers are going to want you to use a GQ or a GT. Those are your original originating or distant site providers. So the distant site is what you'll be capturing for a commercial payer. So the other thing that they finally gave guidance about just last Friday was how FQHCs and RHCs can bill. So for those types of providers, we want G2025 placed on the claim file. And then, of course, remember that you do need to, for FQHCs and RHCs, you do need to waive any cost sharing or co-insurance for the COVID testing or treatment. So you have to add those modifiers if the claim is for that. Next slide. What's not considered telehealth? Telehealth is not telephone calls. So we have two buckets. We have telehealth, which has to be done via interactive voice and audio. If you cannot get your patients to figure out how to work the video portion of the call, then you can resort to doing a telephone call, and there are reimbursement rates for that. You can see from the slide that those are relatively low paying. So obviously we want you to default to the regular E&M visits. But if that is not possible, you can get some revenue out of the telephone codes. There's different codes for the E&M providers versus those that are for dietitians, social workers, PT, O2, etc. Virtual check-in is a little bit different. This is meant to be extremely brief, like 5 minutes, 5 to 7, 10 minutes max. And it is really just as see if the patient does need to have either a telehealth visit or an in-person visit. So you can charge for those. In all of these phone calls, you have to be a little bit careful about if they're closely tied to a previous E&M visit. So if a patient is doing a virtual check-in for something that they have already seen the provider for in the last 7 days, you can't bill both. You can bill one or the other, but if it results in an E&M service, your payment is going to be the E&M visit. Next. You also have online digital E&M visits, and these are also just called e-visits. A lot of people shorten it to that. So you might hear those two terms interchangeably. These are also time-based codes, not super well reimbursed, but again, in a time of this health emergency, sometimes a little bit is better than nothing. So you count this time for not only the time that you are interacting with the patient through the patient portal, but also any thinking time, consultation, lookup, prescribing, coordination that the provider is doing. If you're using staff time to do those types of things, you are not able to count staff time in these codes. You also cannot count other remote monitoring that you might do, such as remote monitoring devices, INR monitoring, for Coumadin adjustment or whatever, self-monitored blood pressures. Those are separate codes, and you can't bundle those codes and count them for your online digital E&M calls or encounters. These all do have to have a patient portal. So next. So obviously, like we kind of already discussed, you'll want to really focus the majority of your effort on the interactive visits. I really appreciate what Katie was talking about as far as having the MAs work through that, some of that, getting it set up with the patient prior to the provider coming on board so that they can maximize that provider time. And I'd be super interested in other kinds of tips and tricks that you've had in promoting telehealth visits with your patients. And Dr. Arzubi, do you have any other kind of tidbits to share about how to drive some of that additional revenue? Or?
Sure. Yeah, no, absolutely. So I wonder as people are kind of thinking about workflow for clinical work is, sketching out workflow that includes these telehealth visits and e-check-ins as perhaps a way, and we'll be talking more about this next week, as a way to kind of figure out who to prioritize. So so again, I think there was a chat comment that came out just now is, I think there's probably a lot of work that people are doing that isn't being captured. And so the more you can capture as part of this triage and prioritization process, the better. The other thing, it looks like on one of the slides, and I know these slides, I think we took them from CMS. There was just, I think there was so if you can go back, keep going, sorry. It was the initial E&M codes. I think they're here. These, I think CMS, no, go back, sorry, there, yep. These, I think CMS messed up on the established patient codes. So just, I want to make sure those should be 99211, 1213, 1415, not 0203. Just so you see, right? There's new patient up top. And so that's okay. And that's just probably CMS error. So just so people don't rely on those codes. And then lastly, what's happening now is people are capturing information online. There's a code number 96127, I believe, and I'll put it in right under message right now. So it's code 96127, and for mental health, one of the things that I do and my partners is we will send forms out like the PHQ-9, GAD-7, and others, and you can get reimbursed for having these forms documented in your notes. So, oh, perfect. Somebody mentions we use this code for depression screening. Perfect. So yeah, so for example, if your patient fills out GAD-7, PHQ-9, and let's say one other one, you can get reimbursed about $5 or $6 for each one of those. And so again, that's just another, if you're creating sort of online forms and people are filling them out, and they're clinically validated forms, that's another way to, you're capturing the data anyway, you might as well get paid for it. So anyway, those are just some thoughts I had.
Awesome, thank you. So even though these aren't considered telehealth, the e-visits, virtual check-ins, phone calls, how many people are actually billing these? Just kind of interested to know if people in the past have thought that this was too small potatoes and not worth the effort, or if you've actively been using these. And then secondly, you know, is that something that you'd like to work up a workflow for? Is that a particular interest, or are you really going to still focus on the actual telehealth visits? Just go ahead and chat in your level of interest in this topic. It'll help us organize our planning for the next webinar.
I wonder, how easy is it to crank out a poll? I've never used the Zoom poll. Is it easy to say, ask that and have people say yes or no? I don't know.
Well, we'd need to set that up beforehand. So if we could just have people just chat it in, that would be great. Awesome. Thank you, Karen. So now we want to open it up to all of you. Just kind of let us know if you have tips and tricks that have worked for you in terms of billing, or if your billers have run into specific kind of hurdles that you'd like to talk about as a group. That would be great.
And I think additionally, with the privacy concerns, if you've had some ways to discuss privacy, we did talk with a couple of our patient family advisors last week that we have for Mountain Pacific. And when I asked them, you know, if they had any concerns about privacy with telehealth, and gave the example that Dr. Razubi gave last week, where he asks if people are, if it's a safe space for them to talk, they said, wow, they had never been asked that before. And I just wanted to kind of throw that out as food for thought too. You know, how many of your providers are making sure that on the other side of that screen, there isn't somebody else potentially listening? Not to say that they need to like get into a big legal disclaimer or anything like that, but just, you know, doing that check with patients to make sure they're in a safe space.
And that can be even, you know, you can even think about that too, Mary, with a lot of people home-based, you know, working from home too, from the healthcare field. And really that's, you know, could hold true for a lot of things in addition to telehealth, when you think about it. We've lost our bricks and mortar, so.
Yes.
Yes.
We don't have walls anymore.
Yes, we don't. One thing I would like to say though, and I enjoyed listening to Catherine, but this is kind of more on the consumer side, but you know, if anybody's really considered just right inside the annual patient agreement, putting in a line that says, I agree to use telehealth and a remote video consult for consultations and treatment. But, you know, putting it right inside, what I like about this is the annual consent form. So you get this signed once, then you're not scrambling, you know, during telehealth to necessarily have that. So I just noticed that one practice did that in Wyoming. I thought it was pretty smart.
Good deal.
Mm-hmm.
And I don't know if Cynthia is on from Ponderay Medical Center. She was also willing to share their experience with PMC. And if not, that's okay. I am going to go ahead and move forward. Thank you so much for engaging in the chat discussion today. We did keep this session to a half an hour. We know that your time is very valuable these days and appreciate you taking some time to move this along. There were a couple of you that mentioned that you're starting out on some new adventures with this, some new billing and stuff. So please let us know if you would like some additional support or some additional coaching sessions as you start to roll some of that out. Our next session is going to be half an hour next Friday, and we're going to talk about remaining gaps, and those are going to be about patient prioritization and the equipment, how to get through some of the equipment issues that our patients and our providers are adjusting to. I do see, before we go any further, a question in chat. Has there been any more clarification on hospital-based therapy telehealth billing? Amber, do you have any more on that, or do we
Question for you, is that specifically for a UB versus a 1500 form? Yes, and it's for PTOT? Okay. I will, if you can throw your, I don't know that off the top of my head to be able to reiterate it right this second, but if you send your email address into me, I will get that back to you guys, and we can include that in the FAQs on our website. That's great. Awesome.
Yeah, great question. We'll get some follow-up. Okay, here's, like I said, all the slides and the recording, the materials, the information that Amber and Dr. Azubi reviewed for the billing information. We are going to make that adjustment, make sure that that one code for existing patients is correct. We'll make sure those are correct, and that'll be also available in handout form and sent out. So that is all for today. Unless somebody has an additional question, we'll hang on for just a few more minutes and make sure nobody has any more questions. But thank you for your time today. Happy Friday. Enjoy, hopefully having some good sunshine in your area, and you can get outside and get some fresh air. Thank you all.